Okay, Assalamu alaikum everybody. This is Dr. Doaa and Nasser, Senior Radiologist from Farwaniya Hospital. I'll be talking today about the cerebrovascular accidents and arterial thromboembolic complications of COVID-19. Starting with the cerebrovascular accidents, I'm presenting a 54 years old gentleman, known case of diabetes, hypertension, ischemic heart on Plavix maintenance dose from home. The patient presented on the 7th of May with fever and cough. Swab was positive for COVID-19. This is his presentation chest X-ray showing bilateral ill-defined multifocal airspace opacities with consolidative patches at both middle and lower lung zones with peripheral predominance, suggestive of moderate stage of airspace disease. As per Farwaniya's COVID-19 protocol, the patient was covered by a full therapeutic IV infusion dose of heparin, and 21 days later, the patient presented with decreased level of consciousness, which required a CT brain. These are the axial cuts of this patient's CT scan. I'll just quickly scroll over. As we can see that there are bilateral multiple variable sized intraparenchymal hemorrhages with bilateral extensive surrounding hypodensities exerting mass effect, and midline shift was measured of around 1 centimeter in this case, and as well as a right-sided ankle herniation. So the patient's level of consciousness was deteriorating. He was kept on mechanical ventilator, high dual ionotropic support, levofid, and dopamine. However, he was hemodynamically unstable, and unfortunately, the patient deceased. This was an article from the American Journal of Neuroradiology titled Brain Imaging Use and Findings in COVID-19, showing 2 cases. I'm starting with the one on the left. Patient A is a 74 years old male patient, known case of COVID. His CT brain showed extensive supra and infratentorial acute hemorrhage and subarachnoid and intraventricular extensions, along with cerebral swelling and hypodensity, likely hypoperfusion injury, as well as ankle supine and transtentorial herniation, resembling much of our patient. Patient B is a 61 years old female, COVID-19 positive, developed right-sided weakness and numbness. Her CT brain showed areas of intraparenchymal hemorrhages with surrounding vasogenic edema. These are cases representing acute intracranial hemorrhages in patients with COVID-19. These are just a few patients of around hundreds of the patients presented in our hospital, showing CT brains with ischemic brain infarct findings, illustrated as areas of cortical and subcortical hypodensities. In these cases are suggestive of ischemic brain infarcts. In the literature, there was an article by the Journal of Clinical Neuroscience, Neurological Manifestations and Complications of COVID-19, as well, showed a 74 years old male COVID positive patient with CT brain findings of hypodensity in the left temporal region consistent of left PCA embolic stroke. This is another article by Centers of Disease Control and Prevention titled Acute Cerebral Stroke with Multiple Infarctions and COVID-19, held in France 2020, as well, supporting the theory behind the hypercoagulability and dysfunctions in COVID-19 patients, as was discussed by Dr. Ziad. Moving into the arterial thromboembolism as a complication of COVID-19, my patient was a 69 years old male patient, no case of diabetes, hypertension, presented with fever, cough, and his swab was positive for COVID-19. This is his chest X-ray on admission, showing bilateral middle and lower lung zones, ill-defined streaky airspace opacities with reticular pattern with peripheral predominance, suggestive of mild to moderate airspace disease. On the same day of admission, the patient was complaining of left upper limb weakness and pain, which required CT brain. However, it was unremarkable. Ward examination revealed pulseless left radial and ulnar arteries. CT angio was requested. These are his corona CT angio images. I'll quickly scroll over. we can see that there is an area of near total occlusion of the left distal axillary and proximal brachial arteries. This is his 3D map image showing the area of filling defect in the discussed arterial segment. The patient was covered by therapeutic doses of heparin during his admission and was gradually improving without interventional procedures and was shifted home on a maintenance dose of warfarin. This is a similar case of the one I've just presented. However, this patient was much younger. He's only 35 years old male, presented with fever. His swab was positive for COVID-19. During admission, the patient complained of left upper arm pain and swelling, bluish discoloration, paresthesia, pulseless bicolor Doppler. CT angio was as well requested. These are his images, and it's showing a total occlusion of the left axillary and brachial arteries. Unfortunately, this patient as well was found to have bilateral pulmonary extensive arterial embolisms. This is an article from the literature, arterial thrombotic complications in COVID-19 patients, showing a 55 years old male COVID positive patient with the same case presentation and was showing subclavian arterial occlusion. This is another article from the literature, thrombosis research, showing venous and arterial thromboembolic complications in COVID-19 having a strong association with the coagulability cascade as described by Dr. Ziad. And I think this will bring me to the end of my presentation. Thank you, everyone, and please stay safe.